going to go ahead and start. This is actually a really important topic, how hormones affect your hair. It's a question that comes up almost at every consultation that we do, and it's an appropriate question because hormones have a huge role in the health of our hair, and in some women, it's the major concern. But in most women, there is some concern in terms of hormones, and I'm going to hopefully touch on all of them. If not, again, please feel free to put your questions in. I'm going to actually take my face off the screen, but hopefully you'll continue to hear my voice. And once the webinar is over, I'll come back on. Okay, so again, thank you for joining us on this kind of cold and dreary spring day. It's a good day to learn something new. And welcome. We're going to touch on quite a bit of information, and some of it may sound fairly clinical, but a lot of you are very well informed as to how hormones affect your bodies, and women in particular do a lot of research on their health and well-being. So forgive me if it seems a little bit too clinical, but I do want to touch on the reasons why we discuss hormones in terms of hair health. So we'll be talking about androgenic or testosterone-driven alopecia, which is the most common cause. It really is the genetic or female pattern hair loss that we see the majority of here. Thyroid diseases are very important in terms of hair health. I'm not going to spend a lot of time on it because it's, again, pretty concise. Cortisol, that's a topic that, again, is becoming more prevalent as an issue brought up in our consults. I think because how stress has affected us, particularly this past year and a half, it has played a big role in terms of our hair health. That's me. Many of you have met with me or my nurse practitioners, so again, welcome. So just I'm going to give a brief summary about female hair loss because it's going to come up in my discussions later. And so just to give you some familiarity with the terms, there are three parts of our hair growth cycle. The first part is the growth phase, which is anagen, and that is the majority of time that any particular hair spends in, hopefully, because that's the growth phase. It can last anywhere from 2 to 6 years. It unfortunately shortens as we age, and nobody is spared that. The catagen phase is the transition phase where the follicle tends to pull away, the root of the hair tends to pull away from the hair follicle. And then the telogen phase is when the hair actually starts to fall out, and then it stays in a resting phase for several months, 3 to 4 months, before it starts to regrow a new hair. So our treatment actually many times is to try and prolong the growth phase or the anagen phase and try to shorten the telogen phase, and hormones do play a role in that, and that will come up later in the webinar. Also, again, genetics, unfortunately, and just aging also tends to shorten that life cycle of any particular hair. Some terminology that will come up is androgenic alopecia, which is the female pattern hair loss or the genetic hair loss that is most common. Telogen effluvium just means excessive shedding. And again, that's going to come up because hormones do play a big part in that as well. We're not going to talk much about traction alopecia or alopecia areata. Post-cancer hair loss, I actually did not mention in the webinar, and I'll just mention briefly here, particularly women who have had breast cancer and are on medications to prevent relapse. Some of those can affect hormones. They're actually anti-androgen or anti-hormonal therapy. And so for breast cancer patients and sometimes ovarian or uterine cancer patients, they are put on that medication as well. And that can also affect hair growth. But we don't see a lot of that here, but it does exist. And then scarring alopecia is not directly affected by hormones, but there can be an association. Again, we just want to make sure you understand that any type of hair loss requires a complete, full evaluation before determining the cause. And so treatment can't be initiated until we know the cause. So here we take a very thorough medical history, a hair loss history. We do a complete physical examination of the scalp and the hair, which includes trichoscopy, which is the instrument you're seeing in that picture, which magnifies the root and we can see what's going on there. We do oftentimes do blood work, and that's where the hormone levels come in. And a lot of times we do hormone levels on almost all of our patients. And again, depending on the age, depending on medication, depending on what we're seeing on the exam, will determine which hormone levels we do. We rarely do a biopsy. It's only when we're really confused as to what's going on, which is very unusual. Or if we think there's a lot of scarring or inflammation, then we will do a biopsy. Again, treatment varies significantly between patients because the cause of hair loss can vary. Okay, let's talk about the most common cause of hair loss in women, which is the genetic part. And androgenic alopecia is driven by testosterone. And it's important to know that all women make testosterone. Everybody thinks that's a male hormone, but women make testosterone as well. So we're going to talk about two parts of androgenic alopecia. One, where the normal androgen or testosterone levels are normal. And again, this is part of the genetic. And it also comes into play when we talk about hormone replacement therapy later on. And again, elevated androgen levels can occur in polycystic ovary syndrome, which is very common in our younger patients. Also, oral contraceptives and IUDs can create an elevated androgen level, and we'll talk about that. And then hormone replacement therapy, depending on what a woman is taking, can create elevated androgen or testosterone levels. So androgenic alopecia, or genetic or female pattern hair loss, this is the most common cause of hair loss in women. It used to be called female androgenic alopecia, which to me made better sense because it actually refers to the causes of this type of hair loss, which is both the hormone as well as the genetic predisposition. There are multiple androgens or testosterones that circulate in our bloodstream. We hear mostly about testosterone, but there are others such as DHEAS, which is a precursor to testosterone. And then DHT, dihydroxytestosterone, which is the culprit in androgenic alopecia. The testosterone gets converted to the DHT, and then the DHT is what affects the hair follicle. And the picture to the right, the top row is men, but the bottom row is women. And it really is the progression of androgenic alopecia. It doesn't progress as rapidly in every person. Everybody's different. And the type of where the hair loss is occurring can vary from woman to woman. Again, important to understand that all women produce testosterone, not nearly as much as men, but enough to be a problem if it's too high. So the incidence of androgenic alopecia, when you do any research, it says anywhere from 20 to 50%, which is a huge range anyway. But actually, I think it tends to be even higher than that, particularly as women age, especially after menopause when our estrogen and progesterone levels drop. So in androgenic alopecia, as I mentioned before, you have normal levels of testosterone, which are converted to DHT at the level of the cell. So at the hair follicle, the testosterone, which is circulating in our bloodstream, gets converted to DHT, which is the culprit. It's the hormone that actually attacks the hair follicle. It blocks the growth, and it causes miniaturization or shrinking up. The hair follicle actually becomes smaller, and the full-size hairs, which we call terminal hairs, become shorter, thinner, and turn into what we call vellus hairs, which are really baby hairs. Now, the big question is, we don't know why certain hairs are affected and others are not. This may be genetically predetermined. There may be something different about each individual that makes certain hairs more affected than others. So again, this is the process that takes place. In androgenic or female pattern hair loss, these predetermined DHT-sensitive hairs continue to get smaller. And as you can see in the picture on the right, the follicle gets smaller. And so as the follicle gets smaller, the hair it produces gets smaller. So over time, as the hairs are getting thinner, they don't provide enough coverage. And so you result in decreased density. And so these hairs also, unfortunately, have a shorter anagen or growth phase, as you recall when I mentioned before, which again, if you shorten that growth phase, it accelerates the miniaturization or the shrinkage of the follicle. unfortunately, as each new hair comes in, it's a little bit smaller. Eventually, some of the follicles will stop functioning and will no longer produce a hair, and then you really start getting spaces. But initially, what it is the hairs themselves are getting smaller, so they don't cover as much. You might have just as many, but they don't cover. But over time, if left untreated, then you will start to lose some. So why does this happen? So now, if the androgen levels are normal in most women with female pattern hair loss, why does this happen? We don't know all the answers to that question. Genetics very likely plays a big role in that. Younger women presenting with female pattern hair loss tend to have a very strong family history in both the men and the women of their family. You know, people think that it has to come from the men. In fact, it can come from the women. It can come from both sides. The genetics and the inheritance pattern for female pattern hair loss is not that simple. I find that the young women that I see, women in their late teens and early 20s, most of them have a dad who has, pretty profound advanced balding at an early age. And unfortunately, that gets passed along to their daughters. The incidence of female pattern hair loss increases dramatically as women approach and then pass through the menopause, again, presumably due to a loss of estrogen, which does affect how much testosterone is circulating. Estradiol is the most active form of estrogen, and that's the one that decreases with age. And it's the strongest form of estrogen. Estradiol and progesterone are the main female hormones. And there's a chart to the right, which shows that the levels increase. It's on the bottom one. They increased to about age 35 to 40, and then they slowly decrease. After menopause, they're very, very low. In some women, it's barely measurable past menopause. Interestingly enough, the testosterone levels in women also increased rapidly to about age 25. They increase significantly during puberty. And then they gradually decrease, but they don't decrease as much as the estradiol decreases, which is an interesting fact to keep in mind. Whoops. Okay, sorry about that. Now, the estradiol drops 75 to 80% after menopause. The testosterone drops only about 20 to 25%. Therefore, that ratio of testosterone to estradiol increases with age. Even though both levels are lower, the ratio, unfortunately, results in less estradiol protection. This is not good for hair. Hair loves estrogen, does not love testosterone. So even though the levels of both have decreased, the estrogen levels decrease at a much more rapid and much more profound rate. And unfortunately, this ratio, which is not in favor of estrogen any longer, does accelerate the female pattern hair loss. Estrogen is good for hair. Just to show you the levels, estradiol, which again is the most potent estrogen in our bodies, premenopausally, it can vary significantly between 30 to 400 nanograms per deciliter. Just to give you some idea, it does vary within our cycle. It increases just before our periods, mid-cycle, just before we ovulate, and then estrogen decreases after that, but it does cycle throughout the month. Postmenopausally, those levels drop from anywhere to 0 to 30. Now, if you look at pregnancy, that level shoots way up to 15,000. And so we all know most women have thicker hair during pregnancy, and estradiol is one of the reasons. Unfortunately, we lose that, which again then can cause shedding postpartum. We also know that if postmenopausal women take HRT, hormone replacement therapy, with estrogen, the testosterone levels do fall. So estrogen does play a strong role in controlling our testosterone levels. And as we lose that control, the testosterone levels is unopposed. Now, having said that, we do not advocate for HRT only for treating hair loss. I don't ever recommend that as the only reason for doing HRT, because there are some potential side effects due to HRT. I think I just moved this along a little too fast. Sorry about that. Okay, next slide. So what is the treatment for female pattern hair loss if we want to talk about how androgens play a role? Should that be part of the treatment? And the answer is most of the time, yes. Primarily, if we want to talk about anti-androgen therapy, premenopausally, spironolactone is a medication which can help block the testosterone. Oral contraceptive pills can also help block the testosterone. And we'll discuss that a little bit more later because there are some birth control pills that are very good for hair, and there's some that actually are bad for hair. The other medication that we use only for postmenopausal women is something called finasteride, and we don't recommend it all the time, but in some cases we do. Finasteride is a medication used for men who are balding. It does work really well for men. It's not as effective for women, but it's something that needs to be considered. And what it does is it blocks the conversion of that testosterone to DHT. And again, DHT is the culprit. So again, anti-androgen therapy may be a part of the full treatment program for any woman, excuse me, with female pattern hair loss. And we also consider minoxidil, low-level laser therapy, and PRP, or optimal platelet concentration therapy, which some of you are familiar with, and we've had webinars discussing that in the past as well. Supplements can also play a role in having some anti-androgen benefits. So what happens when we have elevated androgen or testosterone levels? What happens then, and what are the causes of that? Well, this occurs when the testosterone or the DHEA is actually elevated. There are a few circumstances where we see that. One is PCOS, or that polycystic ovary syndrome. It's a common cause of hair loss in young women, and we'll talk about that. The other thing is androgenic birth control pills. There are some birth control pills that are androgenic or act more like testosterone, and it can aggravate hair loss. The good news is there are many birth controls that are not androgenic, but it's important to know the difference, particularly if you're a woman who's experiencing some thinning at an early age. And very rarely you can have excess testosterone from androgenic tumors of the ovary or adrenal. In all honesty, I've only seen this twice in 35 years of my medical practice, and it's extremely rare, and it's hard to miss because it happens very rapidly. So again, I wouldn't be concerned about that. So polycystic ovary syndrome, what is that? The ovaries actually produce too much testosterone. So blood levels will often show very elevated levels of testosterone. Interestingly enough, it doesn't always show it, but most often it does. And what are the symptoms? The symptoms are hair loss from the scalp hair, acne, obesity, irregular menses. You can actually have increased facial hair, which again, if you think about excess testosterone, that makes sense. Can also cause prediabetes. It often presents with female pattern hair loss in the late teens. And oftentimes a pelvic ultrasound is necessary looking for those cysts. I will tell you that the young woman that I've seen with female pattern hair loss was a young girl who was 14 and 15 years old, and both of them had polycystic ovary syndrome. The good news is they were being evaluated quickly and aggressively to help control their symptoms, including their hair loss. So what is the treatment for hair loss with polycystic ovary syndrome? Well, clearly anti-androgen therapy is important. Anti-testosterone therapy. Spironolactone blocks the testosterone. Another medication called metformin blocks the testosterone. We don't use metformin except for polycystic ovary syndrome. We don't use it for other causes of hair loss. Again, androgen blocking birth control pills, specifically there are 3, Testogen, Yaz, and Yasmin actually help block the androgens. Minoxidil therapy, again, very important for polycystic ovary syndrome hair loss. OPC or PRP, the ultimate platelet concentration PRP therapy we do here, and then supplements. The thing about when you have an elevated testosterone level, anti-androgen therapy is absolutely essential. It's very hard to treat the hair loss if you're not blocking that testosterone. And if testosterone level is elevated on blood tests, the treatment should be aimed at decreasing those levels. And we do see the levels decreasing over time, which is important. Okay, let's talk a little bit about androgenic oral contraceptives and androgenic IUDs. So young women with female pattern hair loss should strongly consider anti-androgenic contraceptives or low androgenic contraceptives. And if you look at the chart on the right, birth control pills have 2 most of them have two components. One is an estrogen, which most commonly is an estradiol, and the other one is a progesterone component. And it's the progesterone component that is variable. And progesterones can actually have testosterone-like qualities or androgenic activity. And so the birth control pills are categorized by high, middle, or low activity of androgenic properties. So it's important when a young woman comes in, if she's on birth control or considering birth control, that if she's having hair issues, that she be put on a low androgenic birth control pill, or even one that blocks androgen, like the desogestrel. So this may seem like a minor point, but it really isn't, because the ones that have high androgenic activity can accelerate hair loss. They're not going to be the primary cause, but they can accelerate it. Most IUDs that have hormones use levonorgestrel, which you can see on the right, is also high androgenic. And so we see women with hormone IUDs like Mirena having shedding, and it's well known to being a cause of shedding. It doesn't happen to everybody, but if the hair loss is progressive, there must be some consideration to making some changes. And it's a tough decision to be made sometimes when it's being used for birth control, but usually we can find an alternate, equally effective method of birth control that won't affect hair. Again, the gynecologists, OBGYNs out there are aware of this androgenic activity, but unless you bring it up as a concern, if that's where you're getting your birth control, you need to bring this up. If you say to your doctor, hey, my hair is shedding, I'm losing hair, could my birth control be a part of this problem? They understand that, and so adjustments can be made without much difficulty. But you have to ask the question. Again, testosterone secreting ovarian or adrenal tumors are very, very rare. And again, I've seen 2 in 35 years. And the one woman in particular that I saw, she had such rapid hair loss. Within 6 months, she was really significantly balding. So again, it's hard to miss. If someone came in with that degree of hair loss over such a short time, we would do the blood levels, and certainly that's what we did and found the diagnosis. So it's extremely rare, but we need to think about it. You don't need to. Okay, let's talk about hormone replacement therapy for postmenopausal women. Hot topic, something that gets a lot of discussion. There's more and more of it being utilized lately. And so when it comes to female pattern hair loss, it's something we need to talk about. 20 years ago, before the Women's Health Initiative study came out, we were using hormone replacement therapy in almost all postmenopausal women for a variety of reasons, and not being particularly careful about it. When the Women's Health Initiative study came out, which showed that there may be some problems associated with hormone replacement therapy, we all put the brakes on, and then nobody got hormone replacement therapy, which wasn't the really correct solution either. So now what we're seeing is more thought being given to replacing hormones for women who are postmenopausal. And so when it comes to hair loss, for female pattern hair loss or genetic hair loss or testosterone-driven hair loss, the most important takeaway is that you should never use testosterone supplementation if your hair is thinning. We see that a lot here. And testosterone supplementation can come in a variety of forms. It can be a pellet, which is placed underneath the skin. It can be creams or patches. Nobody takes it orally, which is a good thing. But the thing to know is that the pellets can cause very high levels in the first months. The pellets are left anywhere from 3 to 6 months. So the levels initially are very, very high, and then they slowly decrease. Unfortunately, once they're in. You can't take them out, and they're often a cause of very rapid shedding. Testosterone patches or creams don't tend to cause the very high levels, but it still can cause some hair loss, and it can accelerate women who are prone to female pattern or genetic hair loss. We never, I should really say rarely ever, recommend PRP or OPC therapy if a woman is on testosterone supplements, because if the testosterone levels are high, we're just not going to get a good response. So it's something that we ask about all the time, and it's important that you understand that if you're on hormone replacement therapy, testosterone may not be a good choice for someone who has hair loss or a strong family history of genetic hair loss. So what about estrogen and progesterone? Estrogen and progesterone appear to be relatively safe for women until they hit their 60s. That's when the cardiovascular risks start to increase, and there's a question, not so much a question, but there's a concern about increased risk of breast cancer and uterine cancer. Now, as I said before, estrogen can be very helpful for hair. But again, these levels need to be monitored carefully. They need to be considered physiologic, which means within good, normal physiologic range. And there needs to be a good balance between progesterone and estrogen. If you remember that chart I gave you about birth control pills, there are some progesterones that actually can act a little bit like testosterone. So if you have too much progesterone and not enough estrogen to balance it out, there can be some hair loss associated with that. Changing doses frequently can add to shedding. And again, levels need to be monitored very carefully. But I've seen some women come in where their doses are being changed monthly. And just the act of changing those doses can cause some shedding. So it's important that the balance be made properly between estrogen and progesterone, the levels be checked periodically, and that they both be in good range. You don't want the progesterone to be higher than your estrogen. The reverse is okay. The estrogen can be a little higher than progesterone in terms of hair. So again, your symptoms for why you're on the hormone replacement therapy need to be considered. But again, the levels need to be monitored very carefully. All right, I'm going to talk a little bit about thyroid diseases and a little bit about Cushing's disease, which are cortisol excess, and then stress, which none of us know anything about stress these days, do we? Okay, thyroid disease and hair. Again, another hot topic and something that really does need to be considered for anybody who is experiencing hair thinning. But both hypo and hyperthyroidism, or low or high thyroid, can cause excessive shedding and sometimes cause a prolonged shedding, which is that telogen effluvium that I mentioned early on. Now, hyperthyroidism tends to cause very quick shedding. Hypo or sluggish thyroid, it tends to be a slower loss. When people are on thyroid replacement, it's very important that labs be checked every 6 months, and most endocrinologists and good primary care physicians will do that. If someone comes here and they're experiencing hair loss and they're on thyroid replacement, we will recheck those levels oftentimes if it's been more than 6 months, just to make sure that the thyroid is in good range. The tests that we check are the TSH, the free T4, and the free T3. Again, the levels need to be in normal range so that it doesn't affect the hair growth. Because some thyroid diseases are also autoimmune diseases, specifically Hashimoto's disease or Graves' disease, there can be a slight association with other autoimmune diseases or alopecia that cause hair loss. Alopecia areata is one that is an autoimmune disease, and scarring alopecias, which are more rare. But again, these are both autoimmune diseases, and there may be an increased risk of these if you have an autoimmune thyroid disorder. Just something to keep in mind. Another interesting thing is many postmenopausal women are being prescribed low-dose thyroid supplements to give them more energy. And then there's no question that as we age, our thyroid hormone levels drop a little bit. Some women, it drops to the point where they're very symptomatic, and on testing it, they find that they are hypothyroid and will need some low-grade supplementation to boost their metabolism and energy level. But I also see quite a few women who really are not really in the hypothyroid range, but their doctors have them on a low dose just to give them a little boost. And I understand the reasons for that. But the important thing to understand is that the levels need to be appropriate. If they're too high, if the thyroid doses are too high, it can lead to active shedding. So again, when it comes to any kind of hormonal therapy, whether it's estrogen, progesterone, testosterone, thyroid, whatever it is, it's important that if you're experiencing hair loss or have a strong family history for hair loss, then those levels need to be managed and monitored very carefully. Okay, cortisol is another hormone that's gotten a lot of press lately. There's a topic called adrenal fatigue, where the adrenal gland stops producing the normal amounts of cortisol. And I've seen some women who are on cortisol supplementation. Cushing's disease is actually when you have way too much cortisol. And it's very rare. Again, in my 35 years of practicing medicine, I've probably seen 10 cases. When this occurs, it's the adrenal glands produces excess cortisol as well as that DHEAS, which is a precursor for testosterone. So you can actually have excess shedding, but also have a pattern of hair loss that looks similar to female pattern hair loss or androgenic alopecia. Stress, boy, have we been dealing with stress in the last year. This can cause a low-level increase in cortisol, and I've seen this quite a few times here in the office. It can lead to increased shedding. It can also, interestingly enough, lead to an increase in testosterone, although it's extremely slight, which can then accelerate female pattern hair loss. Now, stress does not cause female pattern hair loss, but if you have it and you're you're experiencing a lot of stress, then it can increase your testosterone slightly, which we know is not a good thing. These increases can fluctuate. They're generally very, very mild, and they can fluctuate with the level of stress. Telogen effluvium, which is a prolonged shedding episode, has been shown to be caused by slight increased levels of cortisol. And it seems to fluctuate up and down depending on the level of stress, and the shedding tends to follow along with it. Interestingly enough, a very recent study from Harvard showed that when mice were stressed, they actually had increased hair loss accompanied by slight increases in cortisol levels. So we know that our body responds to stress by producing a little bit more cortisol, not to the degree that we see in Cushing's disease. And so it's not going to cause profound hair loss, but it certainly can cause increased shedding. We've seen that a lot this year. All right, so what are the takeaways here? The takeaways is that hair loss can occur as excessive shedding, which again was that telogen effluvium, or very gradually as female pattern hair loss. Both require careful examination and a careful history, as we mentioned before. The trichoscopy is very important. The medical history in terms of medications people are taking. We do check hormone levels almost uniformly, particularly in our younger patients who may have some imbalances of their hormones. We check the TSH, the thyroid hormones, the testosterone levels, both total and free. The free amount of testosterone is the amount that circulates in your bloodstream. The DHEAS, which is the precursor to testosterone, we check for that very frequently. Cortisol levels we don't do uniformly, but if someone is having prolonged shedding and we cannot find another reason for it, we will do cortisol levels. Estradiol and progesterone levels are very important if someone is on hormone replacement therapy. But if someone is perimenopausal, not on hormone therapy, we might check those levels as well, just to see where their bodies are at, to see what's going on. We also do check additional nutritional labs with vitamin levels, ferritin, which is iron, CBC. So all these levels are very important. And so we do check these hormone levels, and we individualize it. It depends on what your symptoms are, what your age is, what medications you're on, what your physical history is. All of that plays a role to determine what levels we check. Okay, if someone has a telogen effluvium and we find that they have a hormone imbalance, again, the telogen effluvium is the excessive shedding. That hormone imbalance must be corrected. If there's a nutritional imbalance, it must also be corrected. If those things exist and are not corrected, then the other treatments aren't going to work very well, which do include minoxidil, low-level laser therapy, and sometimes supplements. So again, the takeaway here is if you're shedding excessively and we find a hormone imbalance, that needs to be fixed, as does nutritional imbalance, because without fixing it, the shedding is going to continue. Now, one little caveat to that, telogen effluvium is very common postpartum. And again, that's because of that sudden drop in hormones. Your hormone levels crash postpartum. We all know how that feels about day 3, when you feel like the world is crashing in on you. Your hormones are crashing. And within 3 months, it's very common to experience an excessive shed. If that's due to postpartum, it's not because of an imbalance, it's physiologic. And so there's nothing that needs to be corrected there. It's really time will help, in which case minoxidil, laser therapy, and supplements may help speed that along. So again, that's the only caveat with Telogen and Effluvium. Female pattern hair loss. Okay, let's talk about younger women, teens to mid-40s. Younger women really need to consider anti-androgen hormonal therapy, whether it's an oral birth control that is low androgenic or spironolactone, which can block the testosterone. We also add to it the minoxidil, low-level laser therapy, PRP, and sometimes supplements, which can also be anti-androgen. But again, the younger you are, the stronger your hormones are playing a role. We know that because the levels are higher. The testosterone levels are higher. We do know it's an issue postmenopausally because of the loss of estrogen in greater amount than the loss of testosterone. So we do sometimes consider premenopausally a lower dose oral hormonal therapy. But around the menopause, just premenopausally, the levels generally are lower that we prescribe. Spironolactone should be considered along with the other treatments that we recommend. So what about postmenopausal? What do we do then? Okay. In terms of treating the imbalance of testosterone to estrogen, the only anti-androgen therapy that might work for postmenopausal is finasteride. Again, it's a medication called Propecia, which is used, men use it a lot. It works great for men. It's not quite as effective for women. And a lot of times we need to use a higher dose. It's not really understood why, but it's still something that should be considered. I only will consider it in postmenopausal women because it has potential side effects that can be quite serious if a woman gets pregnant while on it. So I only will recommend it in women for whom it's impossible for them to get pregnant. And that's postmenopausally. So finasteride should be considered. I would love to tell you it works as well in women as it does in men, but it doesn't. So, but it can be helpful. So we do still recommend other therapies like minoxidil, low-level laser, PRP, and sometimes supplements. Okay, so I've gone through a lot here. I'm not seeing any questions. So that surprises me. Let me just check here. Yeah. So if you have any questions, please type them in now. I'll give it a few more minutes. Oops. But if there's no questions, then, oh, there's one. Okay, good. We'll start. We'll give her a few minutes to type it in. The question is 5% minoxidil is absolutely approved for women? The question is, it says it's not approved for women. It absolutely is approved for women. And the FDA has approved 5% minoxidil for women for many years. So the women that are using 2% actually have to use it twice a day to get the same benefit of 5%. So it is absolutely approved for women. I'm not sure. Okay. The safety of finasteride in postmenopausal women and young men. Good question. There's a lot of controversy. Actually, it's very safe, both in men and women. In women, the only concern for finasteride, and it's a theoretical one, which means that it's not really been observed, is that finasteride can stimulate breast enlargement in men. It's not been seen in women, but again, the numbers of women who have been on finasteride is a very small number. So we tend to not recommend it in women who have a history of breast cancer or a strong family history of breast cancer. Again, it's a theoretical concern, meaning that it hasn't really been observed to be an issue, but we're not willing to take the chance. In young men, it actually is still very safe. The side effects for men are generally temporary. When men have any kind of sexual side effects, and it's recommended that they discontinue it, those side effects tend to resolve. So it is felt to be pretty safe. Rogaine 5% drops for men. Yes, absolutely. That's generally, it shouldn't be marked, minoxidil 5% should not be marketed just for men because it's indicated for both men and women, and it's very safe for women. Progesterone vaginal inserts. Again, progesterone alone can aggravate hair loss, but there are some indications for utilizing progesterone alone. For some women who have very irregular periods, the gynecologist will sometimes use progesterone to help get women through their menopause, where the periods can be very heavy and excessive. And unfortunately, there aren't many other things that can do that. But I don't recommend just progesterone therapy postmenopausally without estrogen, because it does have a negative effect on hair. And for the very same reason, I don't recommend DHEA, which can increase testosterone levels, unfortunately. So I would avoid progesterone only hormonal replacement, and I would definitely avoid the DHEA because it can have a negative effect on hair. It doesn't always. Again, it seems to be some women that are destined to be sensitive to these hormones. So it doesn't affect everybody. But if you're experiencing hair issues, I would avoid both of those. Okay, somebody asked about the estradiol and progesterone levels. It varies from lab to lab, and that seems to be crazy. But in fact, there may be a little bit of variation from lab to lab. So every time a doctor orders a test and the results come back, we are given that particular lab's levels for normal range. So it depends on that particular lab. So I can't tell you what the normal levels should be. It depends on that lab. And they are stated when you get your lab test results back. So it would be, I would follow whatever that particular lab's normal levels are. Different assays can have different levels, and that's why it can be variable. Somebody asked, at what age do you think it's too late to start any treatment? Seems like postmenopausal is a bit limiting with proven treatments. That's not entirely true, and I'm sorry if I gave that impression. It's more difficult to treat the hormonal part of it postmenopausally because of you need to stay away from testosterone. It doesn't mean that these treatments don't work. We do know that the earlier the treatment is started, even if you're postmenopausally, the greater likelihood of success. I mean, I'm postmenopausal. I use all of these treatments. I don't use finasteride, but I do use minoxidil. I do use laser. I have had PRP. They all benefit me. If I know that my hair is healthier than it was before I started treatment. So being postmenopausal doesn't eliminate the likelihood of this helping. In fact, a lot of our women are postmenopausal and do see significant treatment benefit. It's just hard to attack the actual hormone levels. It's a bit harder postmenopausally. You can be on hormone replacement therapy. Once a woman starts reaching her early 60s, the risks do increase some. So rather than being open-ended and saying you can be on hormone replacement therapy forever, which is what we used to do, we want to be more cautious and limit the time frame. But it doesn't mean these other treatments don't work. It just means we have to rely on them more. And they do help. They do work. They do make a difference. And we've seen it hundreds and hundreds of times here. Again, somebody asked, is there a point at which you are too old for treatment? The answer is absolutely not. We've treated women in their 80s with PRP here, and they do get benefit. Again, the earlier that you start the treatment, there's no question the success rate is higher, but that doesn't mean you don't treat. The reality is with female pattern hair loss, which is the most common cause, without any kind of treatment, it will slowly, slowly progress. And so at any age, if you want to stop the progression of your hair loss and try to stimulate regrowth, that's when you need treatment, whether you're 20, 40, 60, 80. If your hair loss is bothering you and you want to get a handle on it and control it, that's when you start treatment. We see a lot of older women here who have varying degrees of hair loss, and we treat all of them. So I would not tell you not to consider treatment if you're in your 70s or 80s. If your hair issues are bothering you, you need to get treatment, and treatment will help. It will. Somebody asked, have I seen long-term success with the low-level laser therapy in those who are young and diagnosed with female pattern hair loss? Yes, we do. Depending on someone's level of hair loss, will determine how aggressive we recommend treatment and how aggressive the patient wants to treat it. Minoxidil, laser, PRP, supplements, all those things will help. We do know they work better together. But success with low-level laser therapy, the studies have shown benefit of greater than 90%. So age is not a factor. We recommend it for pretty much everybody across the board if they have female pattern hair loss. And then somebody asked, do I recommend definitely getting on birth control to treat female pattern hair loss if someone's premenopausally? It depends on the age. Depends on their underlying health. This is a discussion that would need to be made along with your primary care physician, because there's some women, regardless of age, that should not be on any kind of hormonal therapy. But if it's safe for you and your doctor agrees, yes, I think it's something to consider. As a woman approaches menopause, a woman in her 40s, mid 40s to late 40s, the doses of hormones and birth control, we tend to decrease them because, again, there are a little bit more risks in terms of blood clots, cardiovascular risks associated as we age. And so premenopausally, we would consider lower dose hormonal therapy and lower dose birth control. But yes, we do. It's a consideration. Spironolactone, which is also anti-testosterone, should be a consideration. So it's something to think about and a discussion that should be considered. Somebody said that they're 66 and on spironolactone only. Due to age, should she consider finasteride? There are a couple of issues with spironolactone. It may help you. I find that when I was in my general medical practice and we used spironolactone for hypertension and for fluid, as you get older, the spironolactone tends to affect your body's blood chemistries a little bit, potassium, sodium. It is a diuretic, and to get spironolactone doses that are going to be helpful for hair loss, you have to get on dosing high to 100 to 200 milligrams a day. I generally don't recommend it for a woman past 65, only because, again, the body's electrolytes can kind of get out of whack. Should you consider finasteride? I think it's something to consider, absolutely, yes. Do I recommend hyaluronic acid as an HRT treatment for patients trying to avoid estradiol? I am not familiar with hyaluronic acid being used for HRT. I am not a HRT specialist, but I've not heard of hyaluronic acid. It's not really a hormone. So I'm not really sure how that's being used. So I'm a little confused about that question. Sorry. Somebody asked, will I always have female pattern hair loss, or will it stop? Or will I always have to use treatment? That's a hard question. And the answer is, unfortunately, if you have female pattern hair loss, which is genetically driven in most cases, it's something that doesn't get cured. We treat it almost like any medical problem, whether it's diabetes or high blood pressure or high cholesterol, whatever it is. These problems don't get cured. We treat them. And so what I tell my patients is, yes, this is going to continue and will need treatment, and so long as you care. And some women get to a point where they've had enough, whatever that age may be, and they decide, you know, I'm done, I'm going to stop. And unfortunately, when you stop treatment, you oftentimes will lose whatever benefit you've been getting from treatment, and that can be very disturbing. But the good news is the treatment for female pattern hair loss is evolving. It's getting better. There are new things coming down the pike. We're trying new things here. We keep up on all the latest research. We go to conferences, although they're all virtual nowadays, but 2 or 3 conferences a year. We're in contact with people doing research on this all over the country. So we have a lot of contacts. So, we're offering new things all the time. And so if you care about your hair and you don't want it to progress at whatever age, then you're going to need treatment. Minoxidil, she specifically asked about minoxidil. I use minoxidil. I recommend it. Some women don't like using it, but I still think that most women with female pattern hair loss should consider using some kind of minoxidil product. Another person asked if there are side effects using minoxidil for many years. There are very few. And the most common side effect actually is just scalp irritation, which, if it's going to happen, generally happens pretty quickly. The over-the-counter forms of liquid minoxidil have a lot of propylene glycol, which is a form of alcohol, which is very drying, and therefore cause irritation. We use a different form here in the office. We recommend something that has less or no propylene glycol, so it's much less irritating and tolerated. Long term, I'm not aware of any significant side effects. Very little of it gets absorbed into your bloodstream. I'm not going to say it's zero, but it is very little. And so, again, it's not even enough to control your blood pressure, which was what minoxidil was used for many, many years orally. So it's very, very minimal, and the side effects are generally local and just cause irritation. Somebody asked if minoxidil is a hormone suppressor, and the answer to that is no. Somebody asked again about intrarosa, which is something that I don't have a lot of experience with, but I'm going to look it up and get some more information in regards to intrarosa. It's used for postmenopausal women who have a lot of vaginal drying. It's not saying that it's, it acts kind of like DHEA, but it is not DHEA. It's a natural plant-driven form of DHEA. So I don't know. I think it's relatively new. Again, in terms of symptoms, I think it would have to be carefully considered if in fact you had an issue with your hair. But again, I think it's relatively new. I don't have any experience with it, but I definitely will look into it. And if you'd like to get more information, you can contact us, and I'll find out what I can and let you know. I'm not sure I answered this question before. Is minoxidil a hormone suppressor? No, it has no effect on hormones at all. And then the last question, we do prescribe minoxidil through our office. Again, it's a different form than what you get over the counter. It's less irritating and actually has medication to help it absorb better and work better. So yes, we do. Last question, somebody asked, does DHEA have any positive effects? People take DHEA for a lot of reasons. It doesn't have positive effects for hair at all. because it's converted into DHEAS and then into testosterone. So it does increase the testosterone levels. Unfortunately, I've had other patients on DHEA for other reasons, and they feel it gives them a feeling of strength, which again, I think is because of the testosterone that it increases. So it's not going to have positive effects on hair. It's going to have negative effects on hair, unfortunately. So I just will tell people to be careful with it. I don't think it drives the testosterone as high as if you were taking testosterone directly, but I do think it potentially has negative effects on hair. All right, well, thank you so much, all of you, for joining. I hope I answered your questions. I am going to get some information in Intro Rosa, which I don't know much about, to be quite honest, but I'm going to find out because it's probably going to come up again. And if you have any direct questions that we didn't answer, please contact us through email. We'll definitely get back to you. And again, I thank you for joining us. I hope I was able to answer most of your questions, and take care, and everybody stay safe. Bye-bye.